So good afternoon, everybody. So I would like first to thank the organizer for inviting me and letting me present to you a topic which is important to me, so weight stigma in healthcare. And by the way, I will try to answer to the question, does the International Classification of Disease stigmatize? So I have no conflict of interest. So as you know, weight stigmatization refers to a negative attitude towards a person just because he or she is overweight or obese. So a number of studies reports the existence of weight stigmatization in healthcare setting. So in 2013, Swift reported that doctors generally think that obesity is under personal control, which is one of the most important factors that leads to stigmatization. In 2001, Tarman reported that doctors often have negative attitudes to both obesity and the person who is obese, and they think that they are weak-willed, poor controlled, and dishonest. And Christoller, already in 1997, reported that the more the patient become obese, the less patients doctors have, and the desire and motivation to treat them decrease. They think it's a waste of time to follow them, and they have less respect to them. And Forsters and al. In 2003 reported that more than 50% over 600 primary care providers viewed patients with obesity as awkward, unattractive, ugly, and non-compliant. A third characterized them as weak-willed, sloppy, and lazy. And they viewed obesity only as a behavioral problem caused by physical inactivity and overeating. And in conclusion, healthcare professionals have been found to spend less time with their patient with obesity, and there is evidence of a discrimination in terms of treatment option and treatment access, including preventive medicine such as breast or colon cancer screening, and so on. So stigmatization has really a very negative impact on communication on obesity and even on patient willingness to engage in weight management treatment. But what are the other consequences? So poor body image and body satisfaction, low self-esteem, low self-confidence, loneliness, sense of worthlessness, depression, anxiety, and other psychological disorders, suicidal thoughts, and even suicidal acts. These lead to people turning to food as coping mechanism and induce maladaptive eating pattern. The stigmatized patient will be less likely to engage in any kind of physical activity, particularly a physical activity where he thinks he will be more visible. And this will induce avoidance and physical activity. Stigmatization is a stress, and the stress will induce pathophysiology. We'll see it in a minute. And of course, the stigmatized patient won't come again to the consultation. So there will be an avoidance of medical care. So the overall effect will be a worsening of obesity state and its associated cardiometabolic and psychological risks. So this is an interesting study of Himmelstein. It's a study which examined the effect of experimentally manipulated weight stigma on stress response, so the relation between interpersonal weight stigma and the cortisol reactivity. So they studied 110 women, students, which have been told that it was a study on the qualities and activities of a typical student, and that they will have a possibility to have shopping activities. So they fill out first a questionnaire on their self-perceived weight, and you have two response, mainly the one who self-perceived heavy and the one who perceived normal, independently of their BMI. Then there was randomized in 2 groups, the control group and stigma group. Of course, the salivary cortisol level were evaluated at the very beginning of the study and at the end. So to the control group, it has been told, sorry, there is too many people on the shopping activity, you cannot participate. But on the stigma group, it has been told, oh, your size and your shape is really not ideal for this style of clothes. And we want the participant of the shopping activities to feel good and the clothes not to be damaged. So because of your size and your shape, you cannot participate. And it's really very stigmatizing. So what are the consequences? So in the group of stigma, there were a significantly sustained and higher cortisol elevation in the self-preserving heavy participants compared to the self-perceiving normal and to the control group. And this regardless to the BMI, even to the one who had a normal BMI. And this is interesting. So a vicious circle could occur where stigma results in increased cortisol secretion, promoting weight gain and further stigma. And we know that cortisol is a driver of eating and of abdominal fat deposition, so also will induce cardiometabolic risk. So this may explain how stigma exacerbates the risk for weight gain, one of the reasons why. So doctors use in some situations the classification of the International Classification of Disease. So diagnostic criteria for complex medical conditions such as obesity caused by a multitude of both genetic and environmental factors should be descriptive and should avoid the attribution of a causality. And the wording should be evidence-based and should, of course, avoid any stigmatization of the individual. And and so if you see here, obesity have been coded in the chapter endocrine, nutritional, and metabolic disease. So whereas these factors play a role, some very important factors such as energy expenditure, physical activity, psychological factors were not referenced. And ICD-10 emphasizes the importance of nutrition. You can see here obesity due to excess calorie, and we know how it's difficult or impossible to determine it in routine. And of course, this is really stigmatizing. So in ICD-11, the next one, it's still under endocrine, the same chapter, and under nutritional disorders, so it's the same. So in, doesn't want, yeah, okay. So in 2017, the European Association for the Study of Obesity decided to publish an article to improve ICD-11 based on 3 dimensions: etiology, degree of obesity, and health risk in obesity facts. Sorry. So we think that obesity should have its own categorization, because it should be considered as a disease. There is 3 dimensions, so etiology, degree of adiposity, and health risk, which are very important. And you see that we underline that obesity is multifactorial and is the result of complex interaction of a large number of genetic and environmental factors. And this decrease largely the stigmatization. So is there evidence for health inequality for patients with obesity? First of all, the clinician attitude to patients. So historically, clinicians have negative attitudes towards patients with obesity. And you can find this attitude everywhere. So in Europe, in US, in Canada, even in Australia. And it's persistent over time. So already in 1997, it was there until now. And it's not only the doctors, but also the psychiatrists, the psychologists, the nutritionists, the dietitians, the nurses, the physical activity professionals. And in the study of Rushi, more than 50% of primary care providers think that their heavier patients are less likely to follow their recommendation and less compliant to medication. So this can really be very detrimental to the relation patient-physician. So on the communication and behavior, some other studies show that doctors spend less time with the patient with obesity and build less emotional rapport with them than with other patients. And this can also decrease the adherence of the patient to the recommendation or the effectiveness of the behavior change. And for the decision making, some studies show also that clinicians have some difficulties, technical difficulties when performing examination with the patient with obesity and don't have the adapted equipment. And they think that to follow this patient is not rewarding. And they will even not speak about obesity or rarely refer them to weight loss management. So the patient with obesity who feels stigmatized won't go anymore to the consultation and will just go to the emergency service if necessary. So what can we do and what can be successful? There are possibly 5 practical solutions to fight against stigmatization. First of all, the training of medical and paramedical. So it's not also the GPs, but also the medical students already, or the doctors when they are performing their education in hospital. Improving communication with the patient, knowing how to welcome the patient with obesity with full empathy in the medical practice, to have the appropriate medical materials, and to know how to manage and to have a management tailored to the patient with obesity. It's an interesting study of Flynn published in 2015, which report successive intervention. So MDs, medical students in healthcare, have been exposed to 17-minute videos. It was a video produced by the Yale University and entitled Weight Bias in Healthcare Setting. There is 2 parts. You can have it on YouTube very easily. And there is 2 parts. One part where in a practice, healthcare really are very stigmatizing with a patient with obesity. And the other part, the same practice, the same healthcare, but very empathic and very respectful. Then they have been exposed to patients with obesity who had already experienced stigmatization. And then they could also speak about their experience of obesity. This has been really very successful to decrease the external attitude and beliefs towards the patient with obesity. You have also some other studies that reported some success. So it's always programs with multiple components and multifaceted content. So traditional classroom, media-based interaction, so videos, audio recording, etc., websites, role-playing, experimental learning, and exposition to patients. And this intervention should include education of the cause of obesity, increase awareness of weight bias and stigma of the professionals, enhance perspective on obesity treatments, and changing counseling to promote improved health and well-being rather than focusing on weight loss per se. So one way also to decrease stigmatization is to practice motivational interviewing, which is a guided, patient-centered, non-judgmental, respectful counseling style for eliciting behavior change by helping patients to explore and to resolve their ambivalence to change. The healthcare and doctors should maybe also ask to themselves some questions before following a patient with obesity. Do I make assumptions regarding a person's character, intelligence, professional success, health status, lifestyle behaviors based on his or body weight? To what extent is this patient responsible for his or her obesity? What types of feedback do I give to patients with obesity? Does this feedback encourage helpful behavior change? How do I address the needs of my patient with obesity? Or am I sensitive enough to their concern? And the aim would be really to communicate with full empathy and sensitivity, practicing motivational interviewing, for example. So, also to have the appropriate equipment and to weigh the person in a discrete room is very important. But the appropriate blood pressure cuff, so very large, to have a scale or chair without arm, it's armless chair, is very important too. Concerning the obesity management, so the purpose is that it must be really realistic and really negotiated with the patient. And recall that a 5% weight loss of the initial weight is already sufficient to decrease the comorbidity. To treat comorbidity if they are already present, increase physical activity and decrease physical inactivity, to it in full consciousness and with pleasure, and to acknowledge small positive steps in behavior change is also a key to motivation, and to discovery or rediscovery of inner wellness, body image, self-esteem, self-confidence, and self-affirmation. So, how can we help patients with obesity to cope with stigmatization? This is a study of Himmelstein, and with 19 and 12 participants having experienced weight stigma. They were overweight or obese. And they filled up a questionnaire on weight stigma, what did they experience, depression, physical health, psychological well-being, self-esteem, and dieting frequency. And the results were 3 subscales. The one who were responding to stigma with negative emotions, so feeling sad, angry, depressed. The one who responded to stigma with binge eating or dieting, so the maladaptive eating behaviors. And the one who responding with healthy life, to change their lifestyle with healthy lifestyle behaviors. And you can see that the one who were responding, no, The one who was responding with negative affect or maladaptive eating had a degraded health. And the one who responded with healthy lifestyle improved health, of course. So this suggests that one way to buffer against negative consequences of weight stigma may be to support individuals to engage in healthy lifestyle behavior, which is not weight loss, but healthy lifestyle, to help reduce some of the distress resulting from stigmatizing experiences. So one of my conclusions was coping responses to weight stigma may be an important factor to assess before beginning obesity management intervention, to identify potential coping responses that could interfere with effective treatment. Coping stigma-related distress could also be integrated as a clinical component throughout treatment, as a way for clinicians to help patients to adopt adaptive coping response, which could be positive when confronting stigmatizing situations. The other findings suggest two factors by which overweight and obesity remain at high level. Cortisol is obesogenic and elevating by stigmatization, and weight stigma may undermine weight control. And the decrease in stigma in healthcare setting may be achieved through doctors' education, MDs, healthcare, and training, as well as motivational interviewing practice. Stigma prevention in obesity policy should be initiated even during childhood, and one should stress the importance of politician commitment regarding health policy, decreasing its harmful consequences for the patient with obesity. So I will just add a remark. We have produced with the patient council a leaflet that you can have at the patient council desk on the weight stigma and the consequences. So if you're interested, you can have it. Thank you very much.
Great, thank you. So we've got time for questions. If there's a mic at the, yep.
Hello, thank you very much. Really important issue. My name is Louise Bower, and I'm from the University of Sydney. I was wondering if, I was really intrigued about the ICD 11 categorisation. I thought that was a really well-argued approach. Could you talk about how likely that is to be modified and what needs to occur to make that happen?
We try hard, but it has been until now very difficult to get in touch with the responsible. So for the moment, we don't have any response, but we go on, and we really hope to be able to make this change. But for the moment, it has been possible.
Just on that issue, how involved has World Obesity Federation been? I'm just wondering whether that's something that a range of organisations such as World Obesity might be able to advocate.
Yeah, sorry, I didn't understand.
I just wonder whether the World Obesity Federation might be one of the avenues for advocacy, because they are certainly very interested around that issue, the broad issue of stigma and about health services management. Okay. The second question I would ask you, in talking about changing attitudes of healthcare professionals, you were talking about doctors and about allied health. I was wondering if you could reflect on how you might change the attitudes of health managers and people who run health systems, most of whom are probably not doctors and may not have a clinical background. but yet make decisions that are important.
Yeah, this is very, very important. You mean politicians, etc., or you mean
Health administrators,
Yeah. Okay.
Economists, people who run large health organisations.
Yeah, you are quite right. I think we have to fight at every level and every area. And I think it's also very important to make these people aware of the very negative impact of the stigmatization, sure.
I might want to just, if it's okay if I add something to
Yeah.
that. I was just kind of put up here, but I'll put my 2 cents worth in. So in Alberta, in Canada, where I do some work around weight bias and stigma, one of the things that we've done with health administrators, so vice presidents of hospitals, the people responsible for the budgets and decision making, is we've actually had them come through. We have a training program in Alberta that we run to educate them about the causes and consequences of obesity, talking about the impact of weight bias and stigma on quality of life and healthcare. And we also talk about the economic burden of not addressing this properly, that we're actually increasing the cost to the system. And we put them through simulations of what it's like to live with obesity, and we try to simulate that. And we have people living with obesity come and do education with administrators. And what we actually found was, by providing that training and education to the administrators without the healthcare professionals there at the same time, we saw the budgets open up a little bit, and the money to buy the specialty bed, so it did have an impact. So it's an important group, I think, that we often don't think about, but definitely need to address. So, yeah. Sorry, I kind of took over here, but it just, opportunity arose. Yeah. Any other questions or comments? We do have a little bit of extra time. Please help yourself to the microphone.
Thank you for your very interesting presentation. I'm Susanna Lehtinen-Jaks from the University of Tampere in Finland. I just came to think, as you mentioned, that the interventions to reduce stigma should be studied early from childhood. So is there any research on these topics among healthcare professionals who meet families with children or children?
Yeah, I think I have a little problem.
Yeah, I'm sorry. Could you just repeat the last part? We couldn't hear the last part of your question.
Sorry. The question was if there is research on this kind of the same topic, yeah, but specifically among child populations or family populations, yeah, talking about children.
Okay. Yes, of course, there is also research on this topic, and there is a lot to do, because there is a lot of stigmatization on child with obesity. A lot at school, but also a lot with the pediatrician, even, yeah. And it's maybe even worse. I don't know, but it's maybe the impact is probably even worse toward the child than toward the adults. So, but it's also maybe even more difficult to change minds when it's children with obesity than adults.
Yeah.
Mm-hmm.
Any other questions or comments? No?
And you have also stigmatization in family, and even you see that some country want to put fine to the parents who have a child with obesity, so it's a very insensitive subject.
Wow. That should work. Wow, crazy. Well, thank you so much, Dr. Durrer.